All right. So when we're looking at malignant melanoma, what we look for with any intraoral or extraoral pigmentation is changes in that pigmentation. So there's something what we call the A, B, C, D, and E changes, and we'll talk about that in a second. But overall, we're looking for asymmetry, irregular margins, and changes in color, size, shape. So when we look at this, these are basically your A, B, C, D, and E changes that we look for, comparing, is it normal or is it an issue? So asymmetry, we're looking for. So if you see variations in that lesion, that's one of the things. Border wise, we look for irregularities in borders. Is it well defined? Things like that. Color consistency, we want even color versus multiple color. And when we say diameter, changes in size. If the patient tells you, or if we have the patient come back, that's what we look for as that change in size. And the term evolving is noticing that there are some changes. So the lesion is evolving or making changes. And that's why it's good for the patients to be aware of what they have going on and note any changes. So that's some examples of things that you have probably heard when you have a mole of what you should look for. The last pigmentation is the most common intraoral pigmentation you will ever come across. It's called an amalgam tattoo. Amalgam tattoos are also known as dyschromia or phocoaggregosis. And 2 to 1 on a board, they would never use the term amalgam tattoo. They would want to see how much you really know and go with the other terms. Well, the etiology of this is amalgam gets implanted into the surrounding tissue. It's not like we're trying to fill the tissue with the amalgam. It just gets pushed in the sulcus most likely somehow or another. The other thing you can also see is you may see an amalgam tattoo in the person's cheek. If they have a large existing amalgam, it rubs that cheek and actually little particles over time get in the cheek. So those are the reasons why we can have it. Clinically, they're pretty much what we call a well-defined slate gray pigmentation. They're very, unique in its coloration. It's just very gray. They're very well defined in most cases. And what we look at is these tend to be right next to the restoration that they're placed in. Again, if you see one in the cheek, look at where it is on the cheek and do you see an existing amalgam? Now, the other trick is, or the other issue, we are seeing less and less amalgam fillings placed. So you have to look at the history of the restoration. If they had an old amalgam that was replaced, the tattoo may be there and the restoration may be a composite or a crown. X-rays sometimes give you some additional insight. If the amalgam particles in the tissue are big enough, you will actually see it on an X-ray. Sometimes they're just too small. Yes. Go ahead.
So my patient the other day, he has an amalgam tattoo from one of his fillings, and he claims that he gets sensitive in that area. Does any of that cause sensitivity, or is there another issue? Is there something that comes along with amalgam tattoos?
No, that's a good question. Amalgam tattoos, there's no sensitivity with them. 2 to 1, if the filling is large, he may be getting sensitivity from that. It may be like an occasional reversible pulpitis. Or look to see if they have recession. If they have recession, they may be getting the sensitivity from the exposed root surface. Now, when you're in there with your instruments, this is always fun. Take your Explorer on any cervical area and see what the patient does. And if you're scratching on there and they kind of, yeah, well, that's dental sensitivity. But that's what I assume. There's some sort of dental sensitivity. So this is an example of a nice size amalgam tattoo. The amalgam tattoo, you're thinking, okay, well, there's no teeth. Well, you got to remember, they had teeth before. And 2 to 1, these were large amalgams. And it just discolors the tissue. So edentulous areas where the teeth were, you can definitely see it. So this person here has a crown. All right. The crown is not made of amalgam. The filling beforehand was amalgam. And anytime you see a crown, it's telling you that they probably had a large filling and they needed to step up, excuse me, the treatment to protect that tooth. All right. Edentulous right on the ridge. Again, common for teeth to be there. If they have them removed, you may see the amalgam tattoo still. It will not go away. Again, that pigmentation right at that marginal where they had amalgam. Have you ever seen amalgam? Boy. Have you ever seen amalgam on anterior teeth? Amalgam in this location is a weird thing. This patient had root canals. The root canals failed, so they had to have something called an apical. On the root canals, this one had multiple root canals. On the apical area of the root, they exposed it and filled amalgam in the apical framens. They stitched them up. Well, the amalgam leached through and gave it an amalgam tattoo in that area. So history, but radiograph will show actually an amalgam at the end of the root. So that's how you see it. This patient here, very strange area for an amalgam tattoo. Look how far away from the tooth structure it is. But when you take a radiograph, the amalgam chunks are quite large. That's what's creating the amalgam tattoo. When you look at restorative, they have a DO amalgam here. It's far away, but that's giving you your diagnosis, is your radiographic evaluation. Those things are very, very common. You have this comparison of pigmentations. It's a good little thing to help evaluate pigmentations. So I won't give you a chart and say fill it out. I don't want to read that much writing, but it will help you distinguish between pigmentations. All right, so we're going to move to verrucal papillary lesions. Verrucal papillary lesions are lesions that are typically exophytic, and they have these little finger-like epithelial projections that sit above that tissue. So when we look at these, some of these are tough to distinguish one from another because they all look alike. And the only way you can distinguish it is history, but also biopsy it. before I talk about that, I want to make sure everybody knows what a denture is. Everybody okay with a denture? Have you seen a denture? Anybody have phobias of dentures? There's some people that they freak when they have to clean somebody's denture. It just wigs them out. I don't know why, but it does. Well, a denture is used to replace all the teeth on an arch. All right. We also have the term partial dentures. Partial dentures replace a certain section of teeth that are missing. There's different types of partials. You'll notice that this has plastic. We call that acrylic. And it also has metal. These tend to fit better and because they're cast metal and it's basically made around a mold very tight. These are very, very common. These are acrylic. The problem with acrylic is porous microscopically. So if you have a bunch of pores like a sponge, things can get in there. One of the things that we worry about is Candida albicans. And that comes into play when we talk about these type of lesions. The first condition we look at is something called denture stomatitis. All right. The etiology is typically an ill-fitting denture. You can see them with partials, but it's more common because the denture is so much larger, takes up so much space, and the acrylic is more porous. The object with a denture, if my right hand is the denture and this is the tissue underneath, you want it to fit really, really snug. If there's a gap, the gap promotes moisture, darkness, and fungal growth. So that's what the issue becomes. Denture stomatitis is also called denture sore mouth. In most cases, these are asymptomatic, but rare cases you can see somebody says, yeah, my tissues are sore. When we look at denture stomatitis, this is another variation of Candida albicans or candidiasis. So when we think candidiasis, we think a white lesion that is dealing with that fungus. Well, this is a red lesion because it's more of a chronic type scenario. The most common ones you're going to see it under are maxillary type because of the size. The dentures are bigger, the partials are bigger. We tend to see them under acrylic versus metal, right? And we also tend to see them in older females versus males. So why do you think we would see them in older females and not as frequently in males?
Would they be wearing them when they sleep or something like that?
Oh, yeah. Do you realize a lot of females never take their dentures out and they will say, one, they don't want their husband to see them without teeth. And I've even had some of them say their husband doesn't even know they have dentures. So they tend to do it, wear them longer. The other thing is the longer you wear them, you have to give your tissue time to breathe. So we tell the patient, you got to take them out at night. All right. And some women are known to, if they take them out at night, they do it when the husband's asleep and they get up before the husband wakes up and put the teeth in. So what we look at denture stomatitis, when we have that ill-fitting denture or partial or one they're wearing for too long a period of time, we initially see these pinpoint irritations. It almost starts like little splotching, like petechiae. Then it starts to become more diffuse. So this is showing you early denture stomatitis. If you look in this vicinity, you can see these little dots appearing. So it's telling you that is becoming inflamed. So as it progresses, it basically reddens up. And in most cases, you will see imprints of where the partial or the denture sits. So you can tell that the patient wears a partial because of the outline. But all this red inflamed tissue is actually chronic candidiasis. And therefore, we call it denture stomatitis. And here you can tell they have some pressure points where it's sitting. So when you look at this patient, what are you thinking here? Oh, look, everybody's going to be silent now.
Amalgam tattoo?
Yeah, amalgam tattoo, most likely because of location of it. Yep. Good. Another denture stomatitis. You'll notice that it's pretty flat. All right. They have rugae in there and all that, but the imprinting kind of helps. And they're not taking good care of this because look at this. Unique shape of a partial. This person then didn't want to have the palate covered because when you cover the palate with plastic, you don't have the sensation that you get with eating. You don't feel the heat. You don't have as much taste. So that's sometimes why they leave the palate open. This is a complete denture patient, very, very reddened tissues. And again, with these things, you probably look at, okay, you need a new denture, new partial, and you also have to treat the candidiasis as well. If they decide that they're going to keep their denture, you actually have to treat the denture as well as the mouth, because inside the acrylic, it's porous, they have fungus. If you get the mouth cleared up, the denture still has the fungus. When we look at something called papillary hyperplasia, it's also known as palatal papillomatosis. If you can say that one 3 times fast, you're doing good. But papillary hyperplasia is an extension of denture stomatitis. So with papillary hyperplasia, they're going to have the denture stomatitis, that redness, but all of a sudden they have hyperplasia. We use the term hyperplasia as tissue growth due to an increased number of cells in that area. So they're having that same type scenario where they're wearing the denture stomatitis presents, they get the little bitty redness, all of a sudden it becomes very diffuse redness. And next thing you know, they have these little elevations on the tissue. We call them papillary projections. So they're epithelial projections. Therefore, that's what a verrucous papillary lesion is. All right. So it's just a progression. So when we look at this patient has denture stomatitis as a base, but you'll notice these raised areas, these little white areas, debris is getting stuck in the crevices of this. So when they have this type scenario, it's telling you that denture really does not fit well. So with the denture supposed to fit on that tissue snugly, when you create gap and even more gap, that gap, it's almost like saying the gum or oral tissue is trying to fill in the gap. Complete denture stomatitis as a base, the papillary hyperplasia as the raised up area. So once it becomes raised, we kind of call it papillary hyperplasia versus denture stomatitis. We always know there's denture stomatitis or the redness underneath. close-up of these things. The treatment of this is to remove these, you've got to remove them. They do anything from surgical removal if they're less by a scalpel. Sometimes they may take a acrylic burr, which is a big size burr. Think about the size of your pinky. That's the head of it, and grind these things off. And then they make a new denture. Raised up areas, you can see they can get kind of large. And that kind of looks like shingles on a house. Very, very large. More common to see with maxillary full dentures, but again, you can see them with very ill-fitting partials. It also depends on the vaultedness of the palate. You're going to see patients that their palate is very, very shallow. You're going to see some that it is very vaulted. And, you know, when you take x-rays, if they have a shallow palate, it's a little tougher to get that sensor in versus if you have a vaulted palate, a lot easier to get it in. But these are examples of papillary hyperplasia. This is a very unique one because they have a what we call a one-tooth flipper. They are missing a tooth up here, and instead of getting a bridge, it may be finances or whatever. Well, they have a plastic or acrylic partial that has one tooth. Well, it doesn't fit very well. You can see where the partial fits, and it's very ill-fitting, and it has created huge papillary projections. Now, something a little present for you. A hygiene student called me in one time and said, I got a patient that I could swear has a partial. I said, okay, how do you know he's got a partial? She says, it just looks that way. I said, well, did you take it out? She said, well, when I asked him to take his partial out, he said it doesn't come out. I said, what? She says, yeah, I see little hooks, but he says it doesn't come out. So I go in there and I look in there, and sure enough, he's got a acrylic partial. And I said, can you take your partial out? He says, no, it doesn't come out. I said, oh, it comes out. So I basically popped it out. Mind you, he's never taken it out in 15 years. So just what you think, this is what his tissues look like. All that plaque and food, debris has been sitting under there. Some of this could be 15 years old. And you're probably thinking, oh, this is right before lunch. I'm glad I don't smell this. And Carly, you look like you're trying to block the smell. Well, I mean, it was nasty. So, of course, you know me, I'm going to run and go get my camera. It's like, don't you dare touch this patient. I want a picture of this. And then you're probably wondering, I wonder what his partial looks like. Well, there you go. Now you know what his partial looks like. This partial had not been removed in 15 years. So all that crud in there. And if you don't have a phobia of partials or dentures, you probably would have one now. So kind of nice. And when I took that partial out, boy, you should have seen his eyes light up. He didn't realize, I mean, when I took it out, I said, see, it comes out, put it on the table, and he's like, he says, that's really not too clean. It's like you think. All right. The next set of lesions are very similar. We have something called a squamous papilloma. Most people just call them papillomas. It's considered a benign tumor that develops from squamous epithelium. I'm using the term tumor. It's not a cancer. It's a benign growth, would be easier to understand. When you look at these things, biopsy-wise, 50% of them are actually shown to be involved with HPV, all right? So HPV, when you look at HPV, there are 200 strains of human papillomavirus. When we think of oral cancer, we're thinking HPV 16 and 18 are associated with oropharyngeal cancer. Well, 50% of these squamous papilloma, when you cut them out and biopsy them and send them for lab, they are dealing with HPV 6 and 11 are the most common. All right. So biopsy is going to tell you if it comes back, it's a benign growth of epithelial tissue. We tend to call it a squamous papilloma. Most of the time when we see these, we call them a papilloma for the patient versus an intraoral wart, because people don't want to hear they have warts. When we look at these, they're off-white, exophytic. Most of them are pedunculated. So we use the term pedunculated. It grows on a stalk. So it's almost like, you know, if you got this, so you can raise them slightly up, and they're pebbly. So if you take your fingers and put them together like this, that's kind of what they look like. They have these little growth or fronds, and we'll show you what we mean when we look at them. Most of them are solitary. They're single lesions. You see them and you kind of note where they are. Years ago, we used to leave them in. Now they tend to like to remove them because they're HPV associated in 50% of the cases. And our concern with HPV, oropharyngeal cancer, is becoming more and more of an issue with HPV. You can find them in clusters. Clusters kind of tell you the patient's probably more immune compromised, but most healthy patients, you see a single lesion. So this is an example of a squamous papilloma. Off-white, you'll notice that the little finger-like projections, to me, it looks like Bart Simpson's head in a lot of the cases. They're cute little things. When you see them, you'll think, oh my gosh, yeah, that's a cute little lesion. As far as lesions, it's an attractive looking lesion. Here is another one. Again, these little things, when you dry them, they have like little separate fingertips to them, and they can occur anywhere in the oral cavity. You'll see them on the tongue, the ventral surface, the cheek, the palate, soft palate. So pretty much anywhere. This is what they can also look like. They can have normal coloration. If you look at the surrounding tissue, yeah, it looks like within normal limits of the normal color. But you'll still see them as being exophytic, pedunculated, and have all these finger-like projections. This is another cute one. Again, the fingers on this one look more spread out. Common little finding to see. I guarantee you, everyone will see multiple of these throughout your life. And again, they're benign little growths or tumors. And most of the time, we just don't know why they happen. They just happen. Some people still like to believe in just leaving them there, and you kind of just watch them. They don't continue to grow. They typically remain a very small size in most cases. Here's some more examples. And again, nice exophytic examples. They have that nice coloration being white to off-white, and the finger-like projections. Some of them can get more broad in shape, but again, even with the broad ones, they're pebbly in shape. It's pretty neat when you can take your probe and go under this, or take your air water syringe and blow air and watch it kind of raise up and move. I like those versus, if they're flat and wide, they're not as fun to see. I like being able to play with them a little. This one here, dorsal surface of the tongue. You may be saying, you know, that kind of looks like a porpoise coming out of the ocean. Here's his lower jaw. Here's his upper jaw. But it still has those finger-like, and you're thinking, I don't see no porpoise in there. All right. Well, you got to use your imagination. I have a very vivid imagination. This is probably my favorite one. It is really striking in appearance. It has big fingers, long fingers, and short little fingers, but it's exophytic. It's a kind of a nice little thing. The patient did report they liked it there because they played with their tongue with it. And I'm glad you didn't have it cut off because it was a great photo opportunity. The next condition, when you think squamous papilloma, you have to think verruca vulgaris. Verruca vulgaris is the common wart. We know warts are very common to see on skin. Warts intraorally are not as common. But whenever I see a papilloma, I think the same thing, HPV, because high chance, 50% chance of being HPV. So when we look at clinical intraorally, they're going to look exactly like a papilloma, all right? Same appearance on them. Skin lesions are much, much more common than oral lesions. When we think about skin lesions, has everybody seen a wart? Yeah, warts are extremely common. Kids get them all the time. As an adolescent, you can have them. As a young adult, you can have them. You know, a lot of times they go away on their own. Sometimes you have to have them removed or medication. So this is an example of several warts. Again, these are verrucal papillary. If you look at the surface, it's finger-like projections. Most of these are slightly exophytic, but they can get pretty darn tall, to say the least. That pixelated a lot more than I thought. Oh, that's horrible. But multiple fingertips, most common area you're going to see. When you look at oral cavity, again, oral warts are not common. If I saw this, I would call it a papilloma because one, I don't want to tell the patient, this could be an oral wart. Kind of wigs about when you talk warts in the mouth. If we were to remove it, we would send it for a biopsy and they would tell us it's a papilloma or it is verrucus vulgaris. When we look at verrucus vulgaris, how they tell the difference is what HPV is associated with it. So when we look at verrucus vulgaris, HPV 2, 4, and 40 are associated with it. When we look at squamous papilloma, 6 and 11. It just tells you there are a lot of HPV subtypes. Certain ones create different diseases or conditions. So it must be an exciting job to be able to subtype them all. This is another example of an oral wart. Again, look at the finger-like projections. Would you be okay to call it a papilloma? Yeah. You wait for the biopsy report, and if it comes back whatever HPV, it kind of steers you to what the official diagnosis is. Now, there's another condition I didn't put in your syllabus, but I'm going to mention it anyway just because it's interesting. This is a bunch of verrucal papillary lesions. This is condyloma. It is a sexually transmitted HPV. It is probably the most common sexually transmitted disease that is out there. but it is known to create a lesion that's very similar to papillomas and verruca vulgaris or warts. In this case, it's multiple versus single. And when you see multiple, you tend to think immunocompromised. This is an example of another condyloma. Condylomas are sexually transmitted. Most of the time, it's transmitted by direct contact from genitals to oral cavity. That's when we see oral lesions. If you look at this, you may call it a papilloma, and you may think, okay, verruca vulgaris. When the biopsy comes back, if you have to biopsy it, you basically find out it is a condyloma versus the other two. So they kind of all look alike. And that's the problem with verrucal papillary lesions. They do mimic one another. And then this is the last one we'll show you. This is multiple condylomas. And again, these, if you air dry that, that is more finger-like or pebbly in appearance. Oh, yes. Something else for you. You're thinking, oh boy, this will be good. Hope it'd be just like that partial. Carly, what are you doing? You're already hiding? Boy. All right. So I was in the assisting clinic and I wasn't working on this patient. We had another dentist in there, and he came over and got me and says, I got something to show you. Go get your camera. And you know me, man, I run down the hall. I go get my camera. I'm just excited. I don't even know what I'm looking at. Doesn't matter. When another dentist tells you to get the camera, it's going to be a good one. Well, this patient comes in and I look in his oral tissues, and this is what I see. One, you may be looking at those bombed out teeth with the class 5 cervicals, but look at the pebbliness on that lip. Well, the pebbliness on the lip. So then I look and you're thinking, oh my gosh, those are nice teeth. Well, look at all this pebbliness. So I'm thinking, okay, this is verrucal papillary. But then you start looking at this tongue. Oh, come on, there we go. Look at the verrucal papillary on the tongue. So he says, does my tongue and lip look normal? Why are y'all taking pictures? I'm saying, well, no, this is definitely not normal. So I start talking to the patient to try to figure out, why the heck does he have this verrucal papillary lesion everywhere? There are all these little raised up bumps. So I start talking to him, and we, you know, the historical diagnosis really gives you some hints. So he tells me he is a worker. I said, okay, what kind of work do you do? And he says he works in a restaurant. I said, what do you do in the restaurant? He tells me he washes dishes. You know, he does busboy, washes dishes, things like that. And so I said, okay. I said, yeah, we got on the conversation of his hands. So he shows me his hands, and he's got this giant wart. What he was doing.
Luna, what is your problem? Why are you bitching?
I don't know.
Luna.
So he was chewing on his warts with his teeth. So what he did was he spread HPV from his hands to his mouth. Pretty nice. So I found out where he was working, so I wouldn't go there, because if, you know, when you start talking to him, it's like, how do your hands feel when you wash dishes? Well, sometimes I don't wear gloves, you know, I have to hand wash the dishes, and I'm thinking, I ain't going to that restaurant. So I found out where he worked, and I kind of blackballed the restaurant. So, all right, these are my little sister goats. So I'm going to do something here. I got a couple minutes. I'm going to burn the couple minutes once I find out what I'm doing. Let me. All right, we'll close out of that. I don't want that. I don't want that. Ah, all right. Where is she hiding? Ah. All right, so share screen. Let's see. Come on, Foster. Ah, there we go. Okay. Normal versus abnormal. This tooth that you see there, is it normal or abnormal?
Abnormal.
It's kind of abnormal. Have you heard the term hypercementosis? All right, that's hypercementosis. Normal or abnormal? Do you know who she is? Okay, Amanda Bynes. All right, what about normal or abnormal? Tom Cruise jumping up on the couch? Y'all don't remember that? Okay, well, never mind. All right. Normal or abnormal?
Is that a mandibular tori?
Yeah, that's a tori. Kind of weird looking, don't you think? So that's normal for that patient. They can be, all right, normal or abnormal.
Abnormal.
That's a maxillary tori. You ever seen one that big? That's big. So that's a maxillary tori. It's normal for that patient. The sister also had one that big. All right. The pigmentation's normal or abnormal?
Normal.
Normal. Yeah. The cheek, African American, normal or abnormal?
Normal.
Yeah. Normal. Leukoedema. These little yellow dots. Normal or abnormal?
Normal. Are they Fordyce spots?
Very good. All right. Fordyce. Yep. Uh-huh. What about this bump?
Is it from cheek biting?
That's a good guess.
Is it the
Stenson's.
salivary gland?
Very good. Stenson's duct. Oh. Normal or abnormal?
Normal.
Yeah. Exostosi. Radiographic. Are these normal or abnormal?
Normal.
Normal.
Tori. Yep. Big tori when you see them on x-rays. This growth.
Abnormal.
How many of y'all say abnormal? You're thinking, oh man, that doesn't look good. This is a palatine tonsil. Anterior wall, posterior wall. They can come in all kind of weird sizes and shapes. These little things. Normal or abnormal?
Normal.
Yeah. Foveae palatinae. Snake bites in the top. Normal or abnormal?
Abnormal.
This is a normal. This is bifid uvula. So their uvula did not fully develop or fuse. They got lucky. That's a miniature version of a cleft palate. What about this? Or this for that matter. Those are palatine tonsils. They're huge. I got a couple more, then we'll call you quits. Oh, wait, I thought I had a couple more. Oh, yes. What about this?
Abnormal.
Normal. Which papilla on their lateral, posterior lateral? The foliates. Okay. What about those bumps?
Normal.
Yeah, those are normal circumvallates. What about this at the junction, hard and soft palate? Remember the snake bites, the foveae palatinae, the two little pinholes? That's a normal for them. That's a weird variation that you can see. What about all this growth here? These are your circumvallates.
Abnormal.
These are normal. These you do not see very frequently. These are lingual tonsils. The tongue, dorsal surface, front here, back here, circumvallates by my fingertips. The tongue, when it goes down the throat, the lingual tonsils sit here. This patient, when they stuck their tongue out, that's what they did. And the last one. That's their oral pharynx. There's their palatine tonsils. That little growth going up. This is the epiglottis. The first time you ever see an epiglottis, you'll look, see it, and you'll think, did I see something back there? It almost looks like a little snake comes up and it hides. But that's a normal finding. That's your epiglottis.